Now we're going to examine cluster A personality disorders. And remember, these are the odd or eccentric personality disorders. 1 to 4% of individuals have paranoid personality disorder. They mistrust other people and they're suspicious of others' motives. And you see this a lot in schizophrenic patients. That's why it's called paranoid schizophrenia. Clinically, these patients are going to be hypervigilant, tense, irritable. They're going to avoid interaction, and they can misinterpret environmental cues. So if they're not in treatment, they're going to be isolated. They're not going to seek help. And group therapy is not a very good fit for these individuals. Now, 3 to 5% of the population has schizoid personality disorder. And these individuals really struggle to form relationships. They're emotionally detached, indifferent to praise or criticism, emotionally restricted. They have a really hard time expressing feelings, and this does not improve over time. Often they are really focused on intellectual topics. And clinically, you might describe them as odd, aloof, isolated, withdrawn, and very serious. These individuals, in addition, normally do not have any interest in sexual relationships with people. Schizotypal personality disorders are magical thinkers. Clinically, you might see that they have bizarre speech, believe in the sixth sense. Their emotional range might be blunted to inappropriate. So they could laugh inappropriately. They often don't feel accepted in society, can be anxious in social situations or feel isolated. While they have perceptual distortions, they are not delusions or hallucinations. So an example of this would be if I had on black nail polish and somebody on the other side of the world had on black nail polish, and I thought that nail polish and the fact that it matched that person would help me send them messages. That is an example of what schizotypal personality disorder may look like. These are some of my favorite groups of people inpatient, actually. Cluster B personality disorders are known as the erratic or dramatic. So here we have antisocial, borderline, histrionic, and narcissistic personality disorders. 3% of the population is considered to be antisocial, and in prison, that population is about 50%. You're more likely to be a man if you have antisocial personality disorder. And you might be very social and friendly and charming, but also manipulative. There is no known cure. So we often see this personality trait in career criminals. They may be verbally charming and engaging, and they use people. However, they feel that their actions are justified. Brain scans on antisocial individuals showed that when exposed to violent images, the normal brain activity in the limbic system, where empathy lives, it did not light up on scans in antisocial individuals, and it would light up for somebody considered within normal limits. Somebody that's antisocial disregards the right of others. They determine somebody else's weak spots really quickly. So in the orbital frontal cortex, they'll have less muscle mass in the amygdala. So fear, love, fight, and flight is underdeveloped. They often have legal issues, difficulty keeping employment or relationships. For borderline personality disorder, when we think of this personality disorder, we think of emotional instability. So they struggle with impulsive behaviors, self-destruction, struggle with identity, low self-esteem. These individuals fail at assertive communication and often have explosive word vomit where all their feelings come out. They often have a hard time identifying their own emotion but sometimes can feel the emotions of others. Women are diagnosed at a ratio of 4-to-1 for personality disorders. It makes up approximately 1 to 2% of the population. I'm not sure that means that women have borderline personality disorder more often, or if it's just a higher rate of diagnosis. This group of people really fears abandonment. Now, histrionic personality disorder may be an individual who's excited, emotional, or more extroverted. This is 2 to 3% of the population. They like to be the center of attention and like superficially stormy, flirtatious, quick-witted, and maybe talented. So dramatic, attention-seeking, maybe seductive. Narcissistic personality disorder individuals have an exaggerated sense of self-worth. And this is 1 to 6% of the population. They need constant admiration, but they may only be able to engage in shallow relationships. They want other people to meet their need for self-esteem. These individuals have really crushingly low self-esteem. They lack empathy. They're hypersensitive, very self-centered, and think they are superior to everyone else. Cluster C personality disorders include avoidant, dependent, obsessive-compulsive. And note here, obsessive-compulsive personality disorder is not the same as OCD serotonin disorder. There is a difference. So with avoidant personality disorder, these individuals are very sensitive to rejection, and they feel inferior, and they're inhibited and shy. So shy and withdrawn. That's 2 to 3% of the population. Dependent personality disorder has extreme reliance on others, really low self-confidence, and you can see this in their posture and their voice and their mannerisms. They may be passive, overly generous and thoughtful, and underplay their own attractiveness and achievements. For obsessive-compulsive personality disorder, these individuals may be more serious, formal, have difficulty expressing emotions, be very disciplined and perfectionistic, and preoccupied with rules. That preoccupation can lead to inflexibility, lack of spontaneous behavior, and they like to engage in tasks that require accuracy and discipline. Let's do a self-check. Antisocial treatment goals. So if you have an individual who is antisocial, would you want them to complete assertiveness training, verbalize cause-effect understanding in relationships, set limits, encourage socialization, or operant conditioning? So these individuals do not need assertiveness training. They are very assertive, and they don't need to be encouraged to socialize. But they do need to be able to verbalize cause and effect in understanding in a relationship. You need to set limits with them, and they may benefit from operant conditioning. Schizotypal treatment goals. Choose one. Complete social skills training, function independently, and prevent suicide. So schizotypal treatment goals would be complete social skills training. A schizotypal personality disorder diagnosis does not mean that the individual is suicidal. Obviously, if they were, we'd want to prevent that. And they usually can function independently. For borderline personality disorder, we would definitely want to consider suicide prevention and, again, social skills training. For our borderline patients, our goals would be to prevent suicide and set limits. Borderline patients tend to tell us exactly what they need, and so they would not need assertiveness training. For individuals who are dependent or avoidant, to give you a moment to read over these, we would want them to complete assertiveness training and to try an anxiety reduction group and non-chemical coping skills. These individuals don't usually need staff to set limits, but they need staff to help build up their self-esteem and tell them that they can do it. Working with individuals who have personality disorders can be a difficult and frustrating process. These individuals are sometimes destructive or dangerous, but regardless, our job is to treat them with respect, kindness, and compassion. We need to be realistic and maintain safe and ethical boundaries. We might see serious and persistent relationship problems. And remember, they're not just going to be negative things about these individuals, but they're going to be a lot of great things too. A lot of these individuals have been really successful in other areas of their life. People with personality disorders are excessively self-involved, so their focus is themselves. Many are not going to accept that they have problems. They will refuse treatment and they will not change. Now, treatment can be really effective if it is evidence-based, multifaceted, and if the individual is motivated to change. Sometimes it is necessary for family members or even providers to end a relationship with a person who has a personality disorder, and it might be beneficial to seek the advice of an expert when doing so. So treatment, why do patients come in for treatment when they have personality disorders? Well, they also experience things like loss or grief. They might have anxiety or depression, somatic complaints. Perhaps they're referred by an employer, a spouse, or the court, so they're kind of being forced to come. We see alcohol abuse, chemical dependency in these individuals. So you just ask them, why are you here? And they might tell you, someone else asked me to come. When you meet the individuals and assess them, we're going to do a normal mental status exam, history and physical, ask them about suicidal ideation, and really ask about abuse. Have you ever been emotionally abused, yelled at, put down, made to feel bad about yourself? Were you ever sexually abused? Were you ever physically abused? Neglect. What's the worst thing that ever happened? I know you can ask a lot of questions and still miss important things. So if a patient wasn't abused, but they saw their mother being beat every night, well, that's trauma. And so make sure that you ask all the questions when you're doing the assessment. When we think of nursing diagnosis, we think about what defensive coping mechanisms are they using. Remember, these individuals have chronically low self-esteem. So they will be at risk for things like suicide, self-harm, aggression, impaired social interaction. And some of the nursing interventions that we may need to consider are rotating staff. These individuals can be really emotionally challenging, and we want to make sure they get good care. So we might need to take turns, might have more multidisciplinary conferences. And we need to be aware that sometimes we're going to have feelings that we don't want to countertransfer to the patient. Remember, our priority in nursing with interventions is always safety, confronting negative behaviors, setting limits, and to help them with impulse control, reduce their anxiety, and give them hopefully some more coping skills. As always, we want to be professional and maintain their confidentiality. On the unit, one thing that we can do is help them journal and get their feelings out to kind of process. We can help them cope, like I said earlier, with anxiety or obsessions, maybe implement some behavioral modifications. And some of these individuals do really well in partial hospitalization programs, where they either go all day to group therapy or in the evenings. Now, group therapy is not always great for all of these personality disorders, but antisocial individuals, borderline individuals, independent personality disorders can often be successful in some types of group therapy. Some hospitals actually have a borderline protocol established, and that is when the patient comes in who has borderline personality disorder that they only keep the individual for 3 days. And that's because if not, they can become hospital dependent. I believe that Riverside has that protocol in place, but I'm not sure that Ohio State does at this time. So remember, psychotherapy is really helpful for these individuals. Cognitive behavioral therapy, borderline patients do really well with dialectical behavioral therapy. They may need extra services like case management. Family may need some support and additional education. And as we talked about earlier, the antisocial individuals may benefit most with operant conditioning. So in summary, personality disorders are maladaptive behaviors. They're often caused by childhood trauma, and our goal is to develop trust for the patient to be able to trust us so that we can really reach them on a therapeutic level and help them find healthier coping skills so that they can assimilate into society better. And that wraps up our lecture on personality disorders.